heading towards our very last session, that is youth-onset type 2 diabetes and the challenges we are facing. To discuss about this topic, we have our next eminent speaker with us, Dr. Hamadur Rahaman, renowned diabetologist and endocrinologist attached to Medical Super Specialty Hospital. And to chair this particular session, I would like to invite the founder president of Howrah Diabetic Society and the torch bearer of Howrah Diabetic Society, Dr. Sanjay Kesha. So please take your seat and introduce our speaker.
Right after a very successful morning and afternoon, we are going to have a session on youth-onset diabetes and its complications. So we have Dr. Sheikh Hamadur Rahaman, and you can read his CV. He's a well-known academic and works at Medical Super Specialty Hospital. So with those few words, let's hear him regarding youth-onset diabetes. And I think it's very, very relevant in our country because diabetes is nearly 10% in adult population, and nearly 14% have pre-diabetes. So nearly a quarter of our patients who are adults have got some form of dysglycemia, and it seems to be happening to younger and younger people. So over to you, sir. Thank you.
Thank you, Chairperson, sir. A very good evening to all of you. At the outset, I would like to thank the organizers of Howrah Diabetes Society Group for giving me this opportunity to talk on this important aspect of type 2 diabetes mellitus. We know diabetes mainly affects the adults, and we know type 1 diabetes affects the children and adolescents. Now I am going to talk on a new topic, diabetes of youth or youth-onset diabetes. So this is a relatively new concept, but a large number of cases are there. As we delve into our presentation, we will be knowing the details. So I'll be talking on the rising prevalence of youth-onset diabetes, its pathophysiology and aggressive nature. Remember, this is a bit different from adult-onset type 2 diabetes mellitus. The nature of this disease is a bit aggressive and the complications rate are much higher. Of course, we'll talk on the long-term complications of this youth-onset diabetes, the challenges in management, and future outlook and recommendation. So I was talking on this type 2 diabetes mellitus. We know this is a disease that arises in response to long-term insulin resistance and impaired insulin secretion, and therefore affects individuals aged more than 40 or 50. We are taught that this insulin resistance starts from the adolescence, then mid-20s, then 30s, then 40s, and when some other risk factors and environmental factors along with genetic predisposition comes, then it manifests as diabetes mellitus and other metabolic disorders. But here we are seeing diabetes even in adolescence, even before adolescence, even in childhood, and that diabetes is not type 1 diabetes, that is type 2 diabetes. So they don't have this pre-diabetes stage, or they don't have this long insulin resistance stage. So this variety is a bit different from traditional type 2 diabetes and type 1 diabetes. So in contrast to type 2 diabetes, we know type 1 diabetes is caused by autoimmunity that destroys the pancreatic beta cells and typically develops in children, adolescents, and young adults. So this topic, youth-onset diabetes, is described in the literature even in 1960s by sporadic case reports and one or two case series by foreign authors. And it basically came into attention when in 2000, American Diabetes Association, basically they revealed a consensus statement on it, and it stated that up to 45% of new cases of diabetes among individuals aged less than 20 years were not autoimmune mediated. And the majority of these non-immune mediated cases are type 2 diabetes only. So almost half of the diabetes of less than 20 years age are not type 1, but they are type 2 diabetes. So why we have to segregate type 1 and type 2? We know for type 1 we must use insulin from the very beginning. For type 2 we have certain other options. But even more than that, the nature of diabetes and the aggressiveness and complications of this diabetes is much higher than type 1 and type 2 diabetes of adult onset. That I will be talking in bit detail. So the JADE register, there is a joint Asia diabetes evaluation register that included more than 41,000 patients. Basically, they evaluated the metabolic profiles and treatment gaps in young onset type 2 diabetes in Asia. They basically did a cross-sectional study of a prospective cohort. And what they found is 1 in 5 adults with diabetes in Asia had young onset diabetes that is diagnosed before 40 years. That we very often see in our population. Diabetes started at 30, 35, 28, even 20s, even teenagers we are getting diabetes, and those are not type 1. So compared to their older onset counterparts, this youth onset diabetes, they had basically worse cardiometabolic risk factors and complication rates. What about the figure from India? India is not much different. So the figure in India is 0.5 per 1 lakh per year. So there is a registry from north and south, from Delhi and Chennai, basically, and they basically included youth onset type 2 diabetes in India in 2006 to 2012. And it was found that incidence of type 2 diabetes among people aged less than 20 years was estimated to be 0.5 per 1 lakh per year. So it may be the tip of the iceberg, because many diabetic patients we don't know, they are not diagnosed at all. So what is the possible pathophysiological mechanism of this separate entity of diabetes in the young? A lot of postulations are there, but the important postulations are genetic predisposition, and the most important factor of this type of diabetes is in utero exposure of glucose and maternal obesity or maternal malnutrition. And it has been proposed that the maternal hyperglycemia that basically causes change in the epigenetic pattern of the fetus, and that basically lead to diabetes mellitus in the very early age. And these subjects have pancreatic beta cell dysfunction that is much higher than the adult onset type 2 diabetes. They have much higher insulin resistance. Obviously, they will be obese, and they have mental health issues. Certain environmental factors are also there for causation of this type of diabetes mellitus. From the pathophysiological aspect, it has been found that there is greater loss of beta cell function in youth onset versus adult onset type 2 diabetes. And this insight came from the RIDE study. So what was done in the RIDE study? So RIDE study basically examined the insulin sensitivity and beta cell function in adult onset and youth onset impaired glucose tolerance and newly diagnosed type 2 diabetes mellitus. Youth showed higher insulin resistance and secretion than adults at baseline. And after 12 months of treatment, that is insulin glargine with metformin or metformin alone, beta cell function deteriorated in youth but remained stable in adults. If you see these two pictures, the upper one is for adult and the lower one is for youth. Do you have the pointer? No. Okay. So the upper one is for the adult and the lower one is for youth onset diabetes mellitus. We can use this cursor. But that is again not. Okay. So the insulin sensitivity and insulin secretion at a certain point in adult onset diabetes was almost maintained. But if you see the lower curve, the insulin sensitivity index, it fell down after maybe 1 year or 2 years. So the progressive nature of this disease, and there is greater beta cell dysfunction in youth-onset type 2 diabetes mellitus. If you see the long-term complications of these subjects, then we have this 2-day-2 trial, and that basically followed up of these subjects for 15 years. And what was found? This 15-year cumulative incidence of hypertension was 67%. For diabetic kidney disease, it was 54%. For dyslipidemia, it was 51.6%, and nerve disease at 32.4%. Remember, these subjects are younger, maybe in 35, so they all are less than 20 years. So maybe after 15 years, they will be around 30, 35, or less than 40 only. So they are having almost half of the patients, or more than that, they are having microvascular complications. So the implications is much more, and the burden of disease is much more in them. If we consider any microvascular disease, then 80% of the subjects are having at least one type of microvascular complications at 15 years of diagnosis of type 2 diabetes mellitus. So the odds of long-term complications in children and adolescents with type 2 diabetes versus those with type 1 diabetes, so this is much interesting. So we may think, so a type 2 diabetes of 20 years age and a type 1 diabetes of 20 years age, who will have more complications metabolically? So it has been found that adolescents and young adults with type 2 diabetes having significantly higher odds of diabetic kidney disease, retinopathy, peripheral neuropathy compared to those of type 1 diabetes mellitus. So the complications rate are much higher in youth onset type 2 diabetes than type 1 diabetes mellitus. Younger onset of type 2 diabetes at 34 years results in higher hospitalization rates by age 60 compared to those diagnosed later, especially for cardiovascular and renal complications. So this is obvious. If a person is diagnosed diabetes very early, the hospitalization rate at a certain age will be much higher in the younger onset of type 2 diabetes mellitus. Now, how to diagnose? The diagnostic criteria are not different from adult. They are the same. We all know for pre-diabetes and diabetes. I am not going into detail. One thing I want to ensure regarding how long the patient should be fasting to test for a glucose or lipid profile, the answer is 8 hours, at least 8 hours caloric restriction. Patient can drink water, a patient can drink water, no problem is there. So how to manage these cases? This youth onset diabetes has an aggressive clinical course and often leading to early diabetes complications. Managing chronic disease in young patients presents unique challenges. As we see, adult patients, elderly patients, they are not compliant at all in diet, exercise, or medication. So we can't expect very compliance in younger patients. These patients frequently develop end-stage complications by midlife. So this is the most pathetic situation for them. Effective management strategies, including lifestyle changes, medication, and metabolic or bariatric surgeries are the options. So what will be the glycemic targets? For glycemic targets, as we know, the youth onset diabetes, the clinical course is much severe, so we should have a strict glycemic control. We should go for A1C testing every 3 monthly, and our target should be less than 7%. And if the patient is compliant one, if it can be achieved without hypoglycemia, without much complications, without much psychotic issues or psychiatric issues, because these children having diabetes at very tender age, they have to do regular blood sugar testing and restrictions in the diet, in exercise. So they often have psychosomatic issues. So if they permit, then we can have a better control like HbA1c of 6.5% or less. The target should be individualized considering the low hypoglycemia risk in youth with type 2 diabetes. SMBG should be promoted as per family support and compliance. Lifestyle intervention we must ensure, including regular aerobic exercise, dietary modifications. They play a crucial role in managing youth onset diabetes. However, their effectiveness is limited when used alone due to aggressive nature of the disease. Adherence challenge reduce their impact, and pharmacotherapy is essential alongside this intervention for optimal management. So what are the pharmacotherapeutic options we have? other than diet and exercise, we must go for pharmacological therapy for type 2 diabetes mellitus. But the unfortunate part is a lack of clinical trial data for many oral drugs for these subjects with diabetes mellitus. So no guidelines are also there. We can use only metformin, but guidelines, they are silent regarding pioglitazone, regarding SGLT2 inhibitor, regarding gliptins. Additionally, several type 2 diabetic mellitus medications approved for adults lack approval for youth due to insufficient efficacy and safety evidence restricting therapeutic options for this population. This is very important slide. This is data from Hong Kong, basically Hong Kong Diabetes Surveillance Database that included 9,63,000 diabetic subjects. And it has been found that individuals aged 20 to 44 years had the highest mean HbA1c with slowest decline. Basically, they followed subjects up to 20 years, from 1 to 19 years, and it has been found that the upper one, that is the 20 to 44 years age group, they have the lowest decline in HbA1c in comparison to other age group. So younger onset diabetes, they have poor glycemic control and sustainedly poor glycemic control they have, that basically leads to complications. Young onset diabetes patients requires intensified management approach for better outcomes. Once they are having good glycemic control, their hospitalizations rate are also reduced significantly. So what are the treatment options? Treatment options are basically metformin and insulin. If HbA1c is less than 8.5% and no acidosis or ketosis, then we can use metformin and we can basically maximize up to 2 grams per day. If HbA1c is more than equal 8.5%, then along with metformin, we can use basal insulin to start with 0.5 unit per kg per day, and we can up titrate up to 1 unit per kg per day. If there is acidosis or diabetic ketoacidosis or hyperosmolar state, then we definitely start with insulin. Regarding recommendation for bariatric surgery, metabolic surgery may be considered if there is BMI of 35 kg per square meter. Metabolic surgery should be performed only by an experienced surgeon working as a part of a well-organized and engaged multidisciplinary team. So to conclude, youth-onset diabetes is rising globally, especially in overweight or obese children. Developing countries see higher risk due to increasing obesity rates. Youth-onset type 2 diabetes has a more severe course than both youth-onset type 1 diabetes and adult-onset type 2 diabetes mellitus. Treatment options are limited and prognosis is usually poor with youth-onset type 2 diabetes patients requires higher number of hospitalizations. Better understanding and prevention strategies are needed, focusing on high-risk individuals and adherence. Thank you all. Thanks for kind attention. If you have any questions,
Thank you. Thank you very much. Thank you for that lovely presentation.
Thank you.
So any questions from the floor? So while some people think about a question, can I just, one is a comment and one is a question. The comment is, thank you for highlighting the fact that diabetes begets diabetes. Just as we learned hypertension begets hypertension, in pregnancy, pregnant mothers, giving babies born to pregnant mothers with diabetes. There's now evidence even from the Western world, American data from the tribes as well, that diabetes seems to happen earlier in the next generation.
Yes,
so there's an epigenetic phenomenon to that. So thank you for that. But could you perhaps introspect as to why type 2 diabetes in youth is more severe than type 1 diabetes?
Maybe longer duration of diabetes they are going to have. I was going through one review literature and it was written there, because of in utero exposure of glucose, higher glucose amount to these fetus, they have certain deleterious effect on cells which are not replicating much. What are those cells? Nephron. These subjects, they are having more kidney diseases. They are having more neuropathy than the cardiovascular diseases. So they are postulating that these hyperglycemic exposure or in utero toxin exposure basically leads to certain changes in the body that basically prevents those cells from replicating. Which are those cells? Those are nephron, those are these brain cells, and these nerve cells, which basically do not multiply. Plasticity is limited, and those organs are affected much more than others. This is one postulated mechanism. Many other mechanisms are there, sir. They have more beta cell dysfunction than the adult onset type 2 diabetes. Some inherent nature of the disease is like that.
Yeah, I think what you're saying is perhaps there's some truth in what you're saying, but there's another aspect to type 2 diabetes. Type 2 diabetes is not a pure hyperglycemic state.
Yes, sir.
It's a metabolic syndrome. So you also have obesity, you have dyslipidemia, you have hypertension, and all those also drive the similar complications.
Yes, sir.
Which in type 1, you don't get dyslipidemia, you don't get hypertension, you don't get obesity.
NASH,
so you basically are less
sleep apnea.
likely to develop those complications. So that is perhaps one of the reasons why type 2 diabetes in young is perhaps more severe than type 1 diabetes.
Yes, sir.
And apart from what you mentioned about a reduction in the plasticity is also
Yes, sir.
one of the aspects as well. So if there are no further questions, thank you very much. Thank you for that wonderful
Thank you, sir.
session.
Thank you,
very much.
Speaker. It's time to felicitate our speaker. I'd like to request Dr. Shah to please felicitate him. Thank you so much.